This is Dave Meinhardt at the Vaticuti Foundation in Metro Detroit. And I want to thank everybody for joining us today, especially Dr. Kiran and Dr. Bahadur, who are going to be our presenter and our moderator today for this Vaticuti webinar.
Good evening, everybody. At the offset, I think I would like to thank Vaticuti Foundation and mostly Dr. Bandari, who is such a great man. I have no words for him. His encouragement is huge, and he's always been an inspiration for all of us, boosting us to do new things and is encouraging us. We really miss his hosting. We are just waiting for the pandemic to get over so that we can all see each other quickly. And I'm happy to be moderated by my dear friend, Dr. Anupama. And if I think we are done, then we could start my talk.
Can I introduce you, Lavanya?
Yes, please.
It's indeed an honor to be on this platform today, and I'd like to thank Dr. Bandari for giving me this opportunity. It's absolutely wonderful to have Dr. Lavanya Kiran with us, who is a senior consultant, obs and gynae and reproductive medicine and robotic surgeon, along with IVF lab in charge. She has multiple roles. She's at Narayana Health Hospitals in Bangalore. She has received the Foxy Award 2019 for her contribution in obs and gynae. She has received Dr. Balakanda, I will not be able to pronounce it, Swamiji, Samaj Seva Award for the year 2015-16, and has been felicitated for her contribution in the field of women empowerment. She's received the Chairman's Award for Distinct Services Doctors at Narayana Health in the year 2014 and 15, and has received the Kempegowda Award for Samaj Seva 2018. She's been awarded as a surgeon with least learning curve for robotic surgery in India. She's a joint secretary of KISAR for the year 2019 to 2021, founder member of Karnataka chapter IFS 2019, member ACE, member BSOG, member ISAR and PCOS Society. She's member of Fertility Preservation Society, executive member of KISAR. The list is endless. Well, she has graduated from MS Ramaya Medical College, Bangalore, and did her MS from Kempegowda Institute of Medical Sciences, Bangalore, received a fellowship in reproductive medicine from Dr. Patil's Fertility and Endoscopy Hospital, Bangalore. She has an MBA. She is PGDMLE from National Law School of India, University Bangalore, and has been trained in OBS ultrasound under Dr. Ramamurthy Fetal Med Foundation in India. I don't think you've left any field. She's been trained in laparoscopy and hysteroscopic surgeries under Dr. B. Ramesh in Bangalore, and has been trained as a robotic surgeon at Amrita Institute, Kochi, is a trained aesthetic gynecology from Israel, and has received degree of Rashtrabhasha Visharadha from Dakshin Bharat Hindi Prachar Sabha, Chennai. She's received her training in ACLS and BCLS and has been a DNB thesis guide for almost 7 years. She's been trained in Denmark for oocyte tissue cryopreservation and is a TEDx speaker for robotics in November 2017. She's a proctor for robotics in gynecology and has been invited by Taiwan Ministry of Exchange Program in obs and gynae for the year 2019. Well, the stage is all yours, Dr. Lavanya. I hand over the mic to you.
Thank you so much, Dr. Anu, for that wonderful introduction. I'm privileged to be introduced by you. Again, immensely thanking Vaticuti Foundation, Dr. Bandari, all of you for this. So let's start with robotics and infertility, which is the talk today. I always say curiosity is the mother of invention. Because of this curiosity is when we have transformed, and from the days of trepanation, from the days of Shushruta, to open surgeries and minimal invasive surgery in 1940, entering minimal invasive surgeries, which started with cholecystoscopy, then the tubal sterilization, and then the first hysterectomy in 1989. Then the transition has happened from open laparoscopic, and we are in the era of minimal invasive surgeries. Again, the evolution of big scars, vertical transfers, name it, and you can see a lot of scars and huge scars, big scars on all your old patients who come to visit you. And we have evolved through these big laparotomy scars to laparoscopic scars. And today we are looking at minimal invasive surgery in a different form, thanks to Da Vinci, where the incision has come to almost single port and just a belly button hole. But then I always say novelty cannot be equated with benefit or the latest with the best. That is because the enthusiasm of new technology should always be accompanied by a tangible benefit. It is very imperative that we make the right treatment choices based on the credible medical evidences, which is really, really important. An intervention's value resides in its ability to reduce mortality, morbidity, not in its unique mechanism of action. So whenever there is a new technology and you want to try it out, question yourself, is this the right modality of treating my patient? This patient trusts you and comes to you. So every time you take a decision, make sure she fits into that category. And so we can see through the world, there is a huge increase of number of proportions they're going through. In the gynec field itself, we can see there's almost 18 to 25% of increase in the surgical area of gynecology, and different procedures, be it hysterectomy, myomectomy, endometriosis, name it, and all surgical fields, and are being increasing again and again. So today, let's validate robotic as a surgical innovation, especially in the fertility field. We are going to address and see if this is technically feasible as a minimal invasive surgery. Is it safe? Are they equivalent to the conventional open or the lap procedures? Are identical surgical endpoints achieved? Are there specific advantages? Is it cost effective? Do they achieve the same fertility outcome is what I'm going to be addressing through my talk. We already know that minimal invasive surgeries is less estimated blood loss, better post-operative pain scores, earlier return of bowel function, reduced or equivalent operative times, reduced mean hospital stay, reduction in the blood transfusion and adhesion formation, early resumption to work. Then why do we need robotics? So what is so good about robotics that today we are here to validate it as a minimal invasive surgery? And I'm going to tell you that this is good for fertility. So I'm going to validate through my talk, and then you can let me know if you're really convinced with that. Let me walk you through the history a little bit. So the first robot, the mechanical knight, was designed by Leonardo da Vinci in 1498. In the late 80s and 90s, many scientists funded by the NASA and the Defense Agency started using it. In 1995, the Intuitive Surgical was founded. In 1999, the first Da Vinci was introduced. In July 2000, FDA cleared the first robot for laparoscopic surgeries. But the first gynec procedure was done in 2005. Through this process, there has been a huge evolution of the Da Vinci technology from 1999 and post that they've streamlined their innovations, and then dual console came in, then single sides, Firefly technologies, and now we have the XI, we have the X, we have all the fourth generation technology inculcated here. So it's gone through a lot of evolution throughout the process. A lot of brainstorming has happened, and that is how we have a wonderful gadget in our hand, which is making us more empowered as a surgeon, I would say. So before I start, I would like you to understand the parts of the robot. This is especially for the new surgeons who are starting, or people who are interested to become a robotic surgeon, or they're looking forward for robotic surgeries. So the parts of the robot has four important parts, I would say. That is the vision card, the surgeon's console, the robotic instruments, and the patient side card. When we're talking about the vision here, the best is it's a 3D. It's giving us 10 times magnification. Then we have the endorest movement, which is similar to your hand movements. It just moves like how your hand moves. The same replication happens, and you can see it inside your patient's body. And this movement happens through the optic wires, that cables that go through. And this is the intuitive motion where the hand moves and it is replicated to almost inside the abdomen in the similar way. It is also reducing the tremors and then it's giving you 10 times better depth perception. And you also have a dual console capability, which is the wonderful thing, especially when you want to train your junior doctors. So this mimics the surgeon's hands, and the scale down of the movements happen where there is a tremor filtration happening. Even though you have 10 times magnification, you can see that there is no tremor seen at all. And it is exactly how you move your hands, the same thing gets replicated, which is not so in the laparoscopy. Laparoscopy, I would say, is almost the reverse. And the range of motion you get with these instruments, I really love it, I tell you. So the way it moves, it's really unique, and I'm just in love with this new toy, I always call. We also have this Style Pro technology here, where we can simultaneously see the X-rays, sonography can be seen, because so many times you want to correlate what you're seeing and what was your scan, or what was your MRI saying, what was your X-ray saying, what was your CT saying. So this helps us because you can simultaneously view this and see if it's what you want to see. The instruments are lovely, especially the 5 mm graspers, the bipolar dissectors, especially when you want to go deep down. And these are very famous with the cardiac surgeons, especially when they're doing the VAT surgeries, and they'll be like really familiar with this bipolar dissectors. And they all come in 8 mm, 5 mm, and they're really wonderful. And I love the vessel sealers here because it can go up to even 7 to 8 millimeter vessels, and it really gives a good sealing capability. And this is why I love it, because it reduces the blood flow. Blood loss is so less, and then it's compact, and the instrument doesn't look huge, and it can be used really well for sealing. The staplers, again, a wonderful technology innovated here for the instruments. This Endoverest stapler, what happens, it's quite long there, and then it goes deep inside, and it can grasp even your big vessels and seals it when you can just shoot your staples there. And the endoscopes have already gone through a lot of revolution. They've come up with 8.5 mm as well, which is improved and then good for the cosmetic reasons as well. Here, there is a reduced port closure times, and the port opening facilities is really good. Other thing that I like about this is the fluorescence imaging here, where we put in a IG dye there, and then you can actually differentiate between the blood vessel. And sometimes you don't know, are you looking at a ureter? And sometimes you don't know, is it a blood vessel? Is it a lymph node? So it becomes very difficult. So that is when we'll have to turn this on, and then we know whether it is a vessel or is it lymph node or is it anything else. So you can go courageously and see to it that you're clamping the right vessel that you want to. And you can also check on the tissue perfusion in few surgeries. That is, tomorrow if I'm doing a uterine transplant, I look forward to be using the robot to do a uterine transplant tomorrow and come back and tell you how the tissue perfusion was. I'm really looking forward for a few years down the lane to do that. So this fluorescence imaging is really wonderful. I would like to use it sometime where it gives a green hue, and you can really differentiate it, and especially the renal arteries, the lymph nodes. I say I really like it at that time. And then the skill simulators are wonderful because I have postgraduates under me, and they're there and they're always fascinated to use this, but you can't let them sit in the console, right? So you have these skill simulators where they get their hands on, they can move it. And even for me, while my technicians are setting it up, while I'm just whiling away time, it is like a nice warm up for me. So I start using the skill simulator for a while and then go sit in the console. It is also proven, and I believe that a lot of studies done on this. Surgeons, if they start using the skill simulator before they go into the real console, they are much better in their surgeries. And that really helps, and especially for the young budding surgeons, to try their hands on. Like I said, we surgeons never get a second chance. So whatever you're doing the best at the first time is what it is. So you need to really train yourself. Whenever you have time, go use the skill simulators, and that's really going to help you how to control the cameras, how to swap the arms, the needle drive that can be used, and all the manipulations, and you will really fall in love just like me. So I don't have to say that this is such a wonderful technology for a minimal invasive surgery because of its 3D high definition visual, 10 times magnification, the endorest movement with the 7-degree motion, and then the hand movements are replicated precisely and scaled down to smaller movements without any tremors. And this new technology comes with collaborative surgeries and, like I said, skill simulators and the advanced imaging, single site surgery. I'm really looking forward for using the single port surgeries in Da Vinci. And we all know that surgeons are the explorers. So let us go out with this history of the robot, and then let's see what all we can explore, because great explorers are the ones who charted the unknown territories. Why I call it unknown territories? Because if we are not strong in our basics, we are really going to get into trouble. So any surgeon, it is very important they know their anatomy well on the organs that they are dealing with. Since I'm a gynecologist, the fertility specialist, I'll be talking about pelvic anatomy, just about it. It's very important because you will be dealing with difficult cases like endometriosis, myomas, cervical fibroids, adnexal mass. And exactly the reason why I'm mentioning, because I'm a fertility specialist, it's very important for me to preserve everything, because I need to send it home with a bundle of joy. And especially advanced surgeries like the radical hysterectomy, the nerve sparing radical hysterectomy, and excision surgeries, again, anatomy becomes very important. If we are not good at our anatomy, because when we go in, it's like a Pandora box. So you don't know what you're dealing with, because endometriosis doesn't come as simple as it gets shown in the scan. When you go there, it's really hell out there. So it's very important because it looks like a frozen pelvis. You can be getting a grade 3, grade 4 endometriosis. So you don't know what to do unless I'm good at my anatomy. I know where to enter from. And especially in these cases, very important that you know your lateral pelvic walls very well. Apply the anatomical knowledge in your fine surgical skills, and that will make you a good surgeon. The dissection of the correct planes is very important. That is when you cause less injury to the vital structures. To all this, I would say open surgical experience is really, really, really important. And I'm really telling this again and again for all our young surgeons. Don't think you finish it and suddenly you start robotic surgeries. Of course, robotic surgery has a very less learning curve, but then it's very important you know your open surgical experience. Get you good open surgical experience and then jump into your subspecialties, and that is what is very important. Assist more number of cases. I always remember when I was a postgraduate, my senior telling me, the more number of surgeries you assist, that is the way you become a better or the best surgeon, because you observe people doing. That is when you get to know a lot of things. So assist quite a lot of open surgeries, do quite a few of open surgeries, then start your robotic. And even your laparoscopy is very important, because this will train you for your orientation. Use the skill simulators before you start your robotic surgeries. And it's very essential to know and be aware of your major structures and the landmarks at every given point of time. Especially for us, the abdomen is very important, the anterior abdominal wall. How are the vessels going? Where is the superficial epigastric artery? Where's the inferior epigastric artery coming from? Where's the superficial circumflex celiac artery? Because I need to put in my ports. If I do not know this anatomy, I'm going to go and injure the inferior epigastric artery. She's going to come back with a huge blue mark on her abdomen and say, "Doctor, what is this?" They can have a lot of pain. And then we used robot to make sure that she didn't have blood loss, but then you would be ending up giving her blood transfusion, because it can be severe. If it is injured, the inferior epigastric artery is injured, trust me, or the superficial epigastric artery is injured, she can have a big hematoma. Then what is the point of us doing all these minimal invasive surgery? And we can default here if we do not know our anatomy. So that's why I said, please know even the major vessels, where how is the common iliac dividing? Where is it dividing? Internal pelvic vessels, the nerves, everything, because port placement is important. When I place a port, I always make sure my camera port goes at least 10 to 20 centimeter above the target area, I would say. So if I'm looking at a myomectomy, I make sure that I go a little above. The highest or the huge myoma that I have done is a uterus size of around 22 to 24 centimeters. So imagine, so that means it's above your umbilicus. So where do I put my port? So I need to go either much above or the portus point where I have to put. So when I'm doing this, so I have to go up. So it's very important for me to know my anatomy. Usually the camera port goes 10 to 20 centimeters above the target area. And then on either sides, you go laterally away from the umbilicus, where around 8 centimeters, and you can put your other arms. And then your assistant port can go again diagonally up around 7 centimeters. I'm using only 2 arms. Most of my surgery, I think, except the first or the second surgery, I use 3 arms. But I do all my cases just with 2 arms, even if it is a huge myoma. Because of the cost cutting, so I've come up with this plan of just trying to use 2 arms, and that is how I've got used to it. And now almost 200 cases, I do it only with 2 arms. And then if you're using a third arm, then it goes again. Most of the times, I put it on the left arm of the patient, and then another 7 centimeters lateral. And this is how the picture would look, the working ports of the Da Vinci robot, where the assistant ports also come in. And whenever you're putting your port, please make sure you put it under vision. Why do we have to put it under vision? Like I showed you, if you're very careful, you can see your inferior epigastric artery. So you know you're away from that. And then also while you're going in, if you're not seeing your tip, trust me, again, you're in a soup, because you could be injuring your inferior vena cava and direct into your aorta. So there was a study where they told us what is the distance. So this is where our anatomy also helps, because from your umbilicus, your aorta, and your IVC, what is the distance? So if you go 1 centimeter away, then you are 9.5 millimeters away from the IVC and the aorta. And then if you're going 2 centimeters above, your IVC is almost, again, almost 10 centimeters, but your aorta is only around 8-9 centimeters. If you have this good anatomical knowledge, that is when you're not going to get trouble with the major vessels, and you're going to send home your patient happy. And then you will also know the thickness of the abdomen, until, of course, obesity is another contribution. But then you can see in the screen on the left-hand side where the port, as it goes, there is a little thickness. So it is very important you see where you're putting your port, what is the distance, what kind of ports are you using, because if the patient is really thick, that's another advantage. We have the bariatric ports. It comes with a really long shaft that can be used, and that works wonderful for all my obese patients. And obese patients are really hard to manage, but with robotic, I don't think I have anything to complain at all. And like I mentioned, the major consideration, please remember your borders, the anterior, the bladder, the urethra, which is very important, the uterus, the tubes, ovaries, and the rectosigmoid junctions. That is really, really important. These are a few lucky few pictures I have got, where wonderful pictures without any complications as such. I'm not very lucky. Most of the times I get really bad cases, and I sometimes end up regretting, why did I post her? But then at the end of the surgery, especially if I'm using a robot, I am so happy because I chose her to put her under the Da Vinci. And while we know that we have learned our pelvic anatomy very well, and I've told you why it is so important, because once you get in, like I said, abdomen is a Pandora box. You don't know what you're getting. She wouldn't even have any surgeries, but when you go in, there are dense additions, flimsy additions. Like I said, I'm dealing with endometriosis. Trust me, so many times I end up with the frozen pelvis, and I'm like, what do? I just take a breath, sit there. Advantage of robot, you can just go out, come back, and you are just sitting and operating. So that's a wonderful blessing, I would say, in complicated cases, because you can just relax, take a minute there, and then start your surgeries. And this is some of the cases where it's been bad. This is just a few pictures where I have pseudo fibroids and big fibroids. Sometimes they say endometriosis, but I see an ovary totally attached to the lateral pelvic wall, and I really don't know where to start from. And some cases where the ovary is kissing the other ovary, and it's totally adherent to the uterus. And again, to get in is such a big problem there. And they say endometriosis. Sometimes I end up seeing a dermoid there. So I really don't know, what do we do? So this is why I said it's very important, and especially grade 3, grade 4 endometriosis. This is something I really love, and I know I can identify the sacral promontory. For a gynecologist, it's very important that you can identify sacral promontory anytime, any surgery. Take this point from me. Over, I would say, nearly 2 decades I'm operating. So sacral promontory, if you know, just identify where's your sacral promontory, because that is the point where the pelvic cavity starts. And then you start your dissection from the level of the sacral promontory. Try and go lateral. Then you know this is where the bifurcation of the common iliac vessels happen. There is the crossing of the ureter. The ureter is a dreaded point for all gynecologists. And then you know it crosses here, and then you know the superior hypogastric plexus happens here. And if you start dissecting slowly, then your anatomy gets better, and then you can start seeing your structures, what you want to see. And that really helps us. Like I mentioned, the ureter, a great friend of all gynecologists. So we all I don't know how many of them, but I'm sure if I had a poll question here, there would be at least 90 or 95% saying I dread ureter. So I used to always call, please show my boyfriend before I finish any surgery. I always say hi to the ureter and come out, just tickle it a little bit, see the peristalsis, and that makes me feel better. And these are, like I said, a few surgeries where I always make sure that I see the ureter. These are pictures from my surgeries. And over so many decades, like I mentioned, I've almost become a mini urologist. If I'm fearing that something could have gone wrong, my urologists are really sweet. They come in whenever I call them, but then I don't want to trouble them all the time. So I've learned doing cystoscopy. So I go in, see the jetting of the ureter, the urine from the ureters, and that makes me really happy. Trust me, if you don't get your cystoscope, please use your hysteroscope. All gynecologists have your hysteroscope. Don't worry, go ahead, put in a gel, put it into the urethra nicely, and then just use your hysteroscope. You can wonderfully see. So you don't have to be worried, and you don't need a cystoscope. You don't have to buy another cystoscope. You can just use your hysteroscope and see, and then that, I'm sure that's going to give you a peaceful sleep in the night. Another structure, the bladder. Whenever you think you need to push the bladder down for various reasons, you're doing a myomectomy and you have an anterior big fibroid, you want to mobilize the bladder. Again, another tip, try and enter laterally. Always it's better, especially the section. Now you know the section rates are so high, so many people going through cesarean. Make it a point that you enter laterally, and trust me, you are not going to have any injury to the bladder, or you're going to be causing very less injury to the bladder. So these are again pictures from my surgery where the bladder dissection happens smoothly, and then my myomectomy goes well. These are a few horrible pictures where because of endometriosis, bleeding, while separation, it can be really a pain. So all these little tips really works, and I'm hoping that I'm making your life easy. Again, bowel is another, again, dreaded structure. These three things, bowel, bladder, and ureter. While I'm taking consent in the OPD, I tell them again 10 times that they understand. But then with the robot, in my life, it's made me easy. So I always say, when they say, I want to go for laparoscopy, I say, oh, your complication is so much. I don't know sometimes if I'm inflating it. But with robotic, I don't even bother telling them, because touch wood, so far not had any complications, very few morbidities, and compared to my laparoscopic surgery. So I'm really happy. And so I really don't take so much of a pain to explain them about the ureter, bladder, even though I know it's grade 3 endometriosis. I'm very confident. Robotic surgeries have really made my life more confident. So again, pararectal space anatomy is very important, so that you know where to dissect again in the endometriosis, because it can be invading to your bowel. Again, like I said, the sacrum is posterior, and that really saves your life. So identifying your structures is really important. These are again few pictures from my surgery. And again, the nerves are very important, and it's very important that you understand the commandments of the pelvic anatomy, which is again 10. So by heart, the 10 commandments of the pelvic anatomy is what I say. With this anatomical knowledge, now imagine a patient is sitting in front of you. If I tell her, I'm going to identify this, identify that, is it going to help her? No. So what is it? A surgery that we choose is going to have a value to the patient. What matters to her when she's sitting? I'm sure all of you will agree with me. The first thing they're going to ask is how big my scar is going to be. So it matters to our patients, especially this generation. Everybody is conscious about their body, and they have the right to know it. So it's very important. So you can give her the confidence that we are not going to put huge scars. And this is why the patients also understand the same. And that is why they choose a minimal invasive surgery. So we have moved from big scars, vertical scars, transverse scars, like I mentioned, any kind of scars. So compared to laparoscopy, the minimal invasive surgery, I would say the robotic is much better. And then, like I said, I'm looking forward for single ports to be using. And then again, whenever you're advising your patient to choose a particular surgery, make sure you give her all the options that is available. You are here to tell her what are the options. It's the right of the patient to choose what is best. So give them what all is important. They need to know what are the modalities that are available for that particular disease or whatever they're suffering with. So what all options can she choose, including medical management needs to be told to her. And we can see that these days people are postponing their pregnancies, everybody's career oriented, and a lot of things happening. And like I said, a lot of cesareans happening, so surgeries can be really difficult. We are seeing increased number of endometriosis, fertility issues, huge fibroids, small pelvic prolapses are there, and even in people who have one child, because I'm not sure of how much pelvic exercise they're doing, or the not the right type of food as well. So pelvic prolapses are also like in few degrees common. So make sure the patient is given every option and they are going to choose. For a patient, it matters. Like I said, scar matters. They will ask you, am I going to be disease free? So are their symptoms going to come down? What are the complications involved? What is the quality of life that they will be leading a post surgery? Is it really going to make a difference? And cost is definitely something it matters to the patient. Over a long term, pain, blood loss, hospital stay, return to normal activities, they may ask it as an immediate thing, but then it's not going to have a big impact on them. But like I mentioned, your complications, her quality of life, how better is she going to feel, and disease-free feeling is what is going to help her. So it's your duty, because I can't just keep saying your hospital stay is less, your blood flow is blood loss is less, you're going to recover faster, because long term I have understood that doesn't help. So it's your duty to convince her and tell. I always tell my patients, I still continue to do laparoscopic surgeries. I've done huge number of myomectomies through laparoscope. I am doing a lot of cases through robots as well. So I tell them, what is the advantage of me using a robot over her compared to a laparoscopy? I take my time and I tell her, how is robot different from a laparoscope? Because most of us get quite a good educated patients, and most of the patients do have a knowledge of what happens. So they will ask you, what's different? If the incision is same, if the incision is small in both, how is robot different? So we have to educate them of how it is helping me as a surgeon, of how it will help me to send her home and give her a better quality of life, how it's going to help me give her a disease-free post the surgery, how well I can make her improve the quality of life. And when I tell her about the arm movement, sealing capabilities, how the tremors down is going to come down, the scaling down of the movements, the magnification, all these things, if I explain to that patient, they really understand. But we need to be convinced before we talk to a patient, which is very important. So we need to understand the clinical validation of a robot for any surgeries. And there's a huge list that you could be using. And now I don't think any field is left except that we can't deliver babies through this robot. I'm sure someday something will come up and then a robot is just going to stand with the vaginal end and catch a baby tomorrow. So that also will be happening, I'm sure, in the near future. We have enough journals coming to a myomectomy. There's one journal in the Green Obs and Gynae journal where they have done a robotic assisted laparoscopy and they've compared the abdominal myomectomy, and they have seen the surgical outcome here, where the surgical time, the myoma weight, everything has been understood. They have shown that the blood loss was much lesser, hemoglobin drop was much lesser, the length of the hospital was much lesser compared to an abdominal myomectomy. The other wonderful thing I like about this study is they have studied of how big fibroids they could operate in a robot, which compared to a abdomen, because if it's a huge myomas abdomen, the scar is going to be big, again a healing capacity is going to be big. All these things can be done with more confidence in the robotic surgeries. We have enough journals telling us that there was a very short stay when we did a robotic assisted myomectomies by Vargas and then Bedant, and then a lot of people have said the same thing. So here we have to, when we compare to open and laparoscopic surgeries, I am very sure it has less blood loss, shorter hospital stay. Bigger myomas can be removed. Suturing is really, really easy because it's very important. Post-myoma, it's just not removing the myoma, which is difficult. Sealing of those beds is really, really important because they can bleed. So the dead space should be closed. It should not be kept open because the blood can get collected and she can bleed profusely. Only the disadvantage is a little longer operative time in the initial hours. And most of the times, for me, I think the difficulty is not removing the myoma. I get out very quickly removing the myoma, but morcellating or getting that in the cold knife technique as well is what takes a little longer time. So the console time is really less. So I'm planning to do a study only the console time. And when we say a longer duration is the whole thing, like trying to get the myoma also out is included. So only the console time, if you're talking, I would say is really, really less. And little longer operative time, that's only because we would take time to remove the huge myomas that we have removed, because morcellator is a little dicey topic to talk about. You can do it endo bag and then you can use the cold knife, which really takes longer time compared to an abdominal, but the console time is really less. So it has a great potential to become an enabler for minimal invasive surgery. In suture intensive surgeries like myomectomy, trust me, it's really good compared to a laparoscopy. Like I said, I still continue to do lap and robot. I love using the robot for my myomectomies. And like I mentioned, the biggest one I have done is almost 15 centimeters fibroid, where she had multiple fibroids and the uterus was almost 22 to 24 centimeters. Quite a few. I have people traveling across the globe to just go through the myomectomy through robot, and they are so happy and convinced, and it gives me more confidence, and thanks to the Da Vinci for the whole thing. Because of this inspiration, we did a study where we did the short-term surgical outcomes of a laparoscopic myomectomy and robotic assisted myomectomy over 2 years. We had studied around 25 patients, verbal consents were taken. We studied the size, intraoperative blood loss, then how did the surgeries go, how many previous surgeries had they gone through. In robot myomectomy, we had patients who had done 5 surgeries because multiple myomectomy was done, section was done, and appendicectomy. There were patients whom we took very confidently, though they had done 5 surgeries. We were not worried when they chose robot. Like I mentioned, when I was doing a laparoscopic, I would do a lot of time spending on the consent because I had to explain the complications. Most of them with myoma suffered with menorrhagia, dysmenorrhea, and then pressure symptoms. Quite a few of them had and failed medical treatment. Infertility was almost 46% in my caseload. The size of the fibroid, like I mentioned, 10 to 15 centimeters, we operated using the robot. The highest I would take in a laparoscopy was 6 to 7 centimeters. More than 6, 7 centimeters, I'll say either you choose the robot or let's go for open method, because I know during a myomectomy, suturing is really hard. When I'm using a laparoscope, I'm worried about bleeding. Sometimes I'm so hesitant that we take a double consent that if I have to end up doing a hysterectomy for her, though none we have done, but then I'm not so confident. So I always make sure I take a double consent when I'm doing a laparoscopy. Robot we do take, but then I don't emphasize much because I am very confident on the vessel sealers provided by the Da Vinci. So that is really good. The location of the fibroid, again, laparoscopy, I'm a little hesitant in where it is. If it's too posterior and all, I really don't want to do the laparoscopic. But in robot, more than 5, 6 cases where posterior fibroids, huge fibroids, again, all 6 centimeters, 7 centimeters. We had 2 pseudobroad ligament fibroids. They were all 10 and 12 centimeter. We didn't hesitate. We were happy to do because they had flown over from different state to just get the myomectomy done through a robot. And then number of myomas removed were more than 6 and 7 in a robot, almost same in laparoscopy, but then the size of the myoma removed through a robot was much bigger, and most of them were intramural. I'm sure you would read if it's multiple fibroids through a intramural through a laparoscope. Because remember, most of my patients, like I mentioned and gave you the chart, almost 47% of my patients are infertility patients. I have to be very conscious because I am the one who's taking care, because I'm a fertility specialist. They come back to me because I am responsible for the surgeries and helping them conceive. Again, I do obstetrics as well. So I am delivering her. So I have to make sure that whole route map for her is planned and it goes very smooth. And we have to make sure that the suturing of the bed is wonderfully done, and which was very good at with robotic surgeries. And we had seen that the blood loss was very less. Hemoglobin drop was much lesser. Hospital stays were much lesser. These are the few pictures from my surgeries We had 36 years old infertile lady coming with 8 centimeter fibroid, multiple fibroids. This was another 10 centimeter pseudo broad ligament fibroid where she had very bad pressure symptoms. And as a discussion, like I said, less blood loss, less hemoglobin drop. And we had used vasopressin as well, which we used it for both surgeries. What I loved the most was the suturing technique in the myomectomy surgeries, and it really gave me a lot of confidence to operate and help many more people. Coming to another surgery that I frequently do is endometriosis. Before the entry of robot in my life, I would still do laparoscopy for endometriosis, and that is the best because again, all these are mostly infertility patients. Whenever I planned a surgery and what I achieved at the end, I used to have a big gap. I wouldn't be happy with what happened. I would wonder, should I have done an open surgery? But if I did the open surgery, she would have a big scar, again, lot of issues because again, she has to conceive. I have to do an IVF for her because sometimes the tube can be bad, knowing her endometriosis. I know her quality of eggs are not good. She will be a IVF candidate at some point. So this gap that I always felt in my life was fulfilled by the robot. And this gap really bridges between what a surgeon wants and what is achieved is done only by the robot. So to substantiate what I'm telling, we had a lot of journals. So when I went through, we could see this was one of the actually a big study in the Da Vinci, where they have a huge number, I cannot remember, somewhere around 700 patients they had studied. And here the histological confirmation of endometriosis was significantly higher for the robotic cohort, suggesting robotic assisted technique provides accurate visualization and excision of the existing endometriosis. So you are not going to remove a normal ovarian tissue there. Like I said, these are for fertility patients. If I remove the normal ovarian tissue, then her reserve is going to come down. How can I help her to conceive? So it will really help me realize what is the demarcation, what is the border that I stop, where is the normal ovary starting, where is the endometriosis ending, where is it? So I know precisely to where to go in, and the depth perception is so good. Even like I mentioned, grade 3, grade 4 is good for me to operate through a robot, especially when I've posted through laparoscopy cases. I have converted quite a few saying I cannot do it laparoscopically because I do not want to injure and give her more morbidity. So we've converted. Like I say, always say, touch wood, robot, not a single endometriotic cases, even grade 3, grade 4, we have not converted. We've gone ahead and helped them. And quite a few of them have conceived, and that is what says an SART study, Cysto study. They all say less complications. They've done wonderfully well. This is another study done in our institute for the endometriosis. And again, we could we had evaluated almost 40 patients over 3 years for endometriosis with previous scars and menorrhagia, cysts on bilateral, unilateral side. Almost 65% had unilateral cysts. Stage 3, stage 4 endometriosis, where 20% of them, none of them had a bowel or a bladder injury so far, I would say. So I keep my fingers crossed to make it zero over many more surgeries to come across. So they all had less blood loss, need of vasculitis were almost in 60%, but still no injuries. Hospital stay was still mean of just 2 days, even with grade 3, grade 4, which I don't think I would achieve it even in open or a laparoscopic. The post-operative pain was wonderful. Just very few people had pain. I would say only 5% of them complained of pain when I went for a post-operative rounds. I would operate anywhere around 2 to 10 cases in a day. And when I go to my post-operative ward, I can always know, and I know whom I have done a robotic, because she's the only one who's just sleeping there without making much of noise. But otherwise, everybody is like, I have pain, rolling down in their bed. And then we know she's not a robotic surgery. So I can really make out whom we did a robotic surgery because her pain is way less. And these are again a few pictures from my surgery. This is one of the grade 4 endometriosis. Totally stuck. We didn't know what to do. Like I mentioned, anything you dissect, so it was bleeding, and then we put in a gauze to just control some bleeding. And that is when I realized my sacral promontory. This is why I said I'm giving you all tips through my surgical experience for you. So identify the surgical promontory, grow from the lateral, start dissecting, and then you get in, you know where your fields are. So it becomes much better. you start seeing the structures that you want to see, and then it helps you plan your surgeries. Again, this is on the right side, we have a grade 3 endometriosis, where you can see both the ovaries are kissing each other, totally adherent to the posterior part of the uterus. You don't know where it is. On the left hand side, I have a dense omental adhesion. I didn't know where the uterus was. So we have to really be patient with these surgeries. Go ahead, dissect slowly without injuring your structures. And again, the anatomy plays a very important role here. And if you do it, you can wonderfully send home with good results to your patients, where they come back with the joy because they are symptom free. So again, the advantage here is low complications, ability to do difficult dissection, low conversion rates. Histopathological confirmation is very important. I don't want to be talking about cost and operating time when it comes to endometriosis, because patients are not looking at cost. Like I told you, patients have come here to me after 4-5 surgeries because they're wanting to be symptom free. Here, cost is not a factor for them. Operating time is not a factor. So there is a reason why we have to choose a robot. And I say robot has an advantage over the lap in the complicated endometriosis, with organ involvement, making the dissection easy and complete and decreasing the complications for her. So again, I always say the advantages over the laparoscopy, the 7-degree, the scaling down movements, all the arms are under my control. Being a laparoscopic surgeon, I know it is so difficult when you don't get a good assistant, because they're not showing you what you want to see. They're not moving in the right direction the way you are thinking. Here in a robotic surgery, I don't have to be worried because all arms are under my control. I see what I want to see. I move my arms the way I want to move it. I go in when I want to go in. Nobody's stopping me from it, or I am not dependent on my assistants. Of course, a little bit of assistant port is very important when the bleeding is huge. Of course, the compliments goes to them as well. And this is my wonderful support team who will not let me convert my grade 3, grade 4 endometriosis, my huge myoma. Sometimes I'm so dead tired, but hats off to my support team who will not let me convert. They say, ma'am, take 10 minutes break, go out and come. Like I said, that is another advantage of Da Vinci robot, where you can just go, come back, sit and operate, especially the long surgeries, difficult surgeries. And a party is a must post any big surgery, and it's a dictum or the rule for our unit. And thanks to all these people who have been a great support to me. Another few surgeries, very few surgeries, I would say tubal recanalization. I have done quite a few in the open method, very little in laparoscopy. Robotic, I've started my hands on this. Why I thought I will start using robot for the tubal recanalization is because of the magnification that is giving. You know, the tubal recanalization is such a fine surgery. It's like almost you're doing a cardiac surgery where you're trying to unite the veins. So, you know, your fallopian tubes are just like a millimeter, 1 to 2 millimeter you get. And then you have to be really fine in your surgeries, trying to meet both the ends, especially in my people who want another baby for several reasons. We don't want to get into that. So when they come back for tubal recanalization, I've had good pregnancies in open. Like I said, I'm very in the baby stages, infant stages for robotic in the tubal recanalization, yet to see the results. So we have enough studies over time by Margosians, Falcon, Goldberg, Duglardi, who's always told that tubal recanalization is done. Deglard has done almost 2,000 tubal recanalizations, and he has seen quite a huge number of patients with good tubal patencies. Almost 40% pregnancy rate is what he claims. And so I think that is wonderful if we can give this. And why I like using the robot for a tubal reanastomosis is here we get the benefit of microsurgery. And again, the benefit of laparoscopy, because we're doing it in a minimal invasive. So the abdominal incision is there. Why are we giving big incisions? Because we want to see it well. And that is achieved in my robot, but I want to do it through smaller scars. So both the benefit of laparoscopy and the benefit of open microsurgery is all achieved through the robot. And I think it's a wonderful instrument because it gives us the edge over using for smaller organs as well, like the tubes, especially. Sacrocolpopexy, like I said, sometimes this is a small descent, and then we want to use it and we want to help her conceive again. We can use a mesh. So, you know, if it's an open surgeries, they've gone through a lot of surgeries before, lot of additions, it can be a lot of complications involved. So robot is a wonderful instrument to be used for her, and this will give us good results with lesser infections and better healing for us, for her as well, and complications are going to be less. Again, blood flow is going to be less, and here they have told minimal invasive group at shorter hospital stay, less blood loss, and longer operative time, like I said, is not comparable at all because we're looking at results. And compared to laparoscopy, they did have a lot of complications. These are a few accomplishments of mine. And this is pictures from my TEDx talk in 2017. And I have also contributed a chapter on robotics in infertility. I do quite a few cases on fertility patients. I'm really looking forward for the single port. I keep troubling Dr. Bandari asking when is the single port coming to India, because I do ovarian tissue cryopreservation for my cancer patients. So I don't want to put 2-3 ports and try and get the ovarian tissue and freeze it. So I want to start using the single port. So I'm trying to wait and use it. And in my fertility services, we have quite a few of obese patients, especially the PCO patients. The highest I've had is around 140 to 150 kgs. I don't dread because I have the robot right next to me who's going to help me operate on these obese patients. Where it is so good, I am really not worried. Like when I'm using a robot, I really don't concentrate. As a completion, I talk to them about the complications, but really don't insist too much and scare the hell out of them if I'm doing compared to a laparoscopy or an open method. Even in these obese patients, I have seen their hospital stays much lesser. The complications are much lesser. Wound healing is something that we really dread in obese patients. I've had few complications in the open, and I don't want to talk about what all complications I've got into in the open surgeries, but none in robotic surgeries, though we have done quite a few there. Wound complications is not something. So any obese lady walks in, I say, you are going to go for the robotic surgeries. And sometimes cost is a factor for them. Then I say, if it's the cost, this is why I said, because of these cost factors, I have shifted myself from 3-arm to 2-arm. Like I mentioned, even huge fibroids, I swear I use only 2 arms. So that brings down quite a good costing for the patient. And the learning curve has been really smooth for me. Initially, I had a little scary situations in the first couple of surgeries. By third surgery, I think I almost started getting comfortable, started giving me a good high. So initially, when you start posting, please start posting less complicated cases. Talk to your patients. I told my first robotic patient that you're the first patient of mine that I'm operating. She was a wonderful patient, long time known patient to me. She was very happy to go through her endometriotic cyst, and she's doing wonderfully well. Of course, you master over 50 cases, and I say you plateau after that, so you don't have to get worried, but you can definitely start doing. But please remember, you need a good exposure for your open surgeries as well. Just as an overview, the robotic advantages: short learning curve, proficient with robotic with lesser number of cases, and I am one of the examples for that. Vision of magnification in 3D form, increased depth perception, counterintuitive movements, eliminates the need to assistant held laparoscope, which I really love, and results in lesser tremors. The fulcrum effect of the laparoscopy is abolished, so you don't have to hold those long ones and start operating. You can sit and operate. Endorist movements, the fly-or-fly technology, which I love, is there. And then it also allows the easy suturing methods in complex dissections, superior precision, less complications, less blood loss, less blood transfusion. Motion dampening sensors prevent the tourniquet at the port site and less patient discomfort later. Significant reduction in the conversion rates. Ergonomics, the surgeon control of all the 3 arms, and the best modality for morbidly obese patients. Of course, we do have the drawbacks like the high cost, longer operating time, large OR space is required, difficulty in changing the table. But then with the 4th gen, I don't think we have to be worried about the docking and changing the quadrants and all these things. And the feasibility of approaching the quadrants, I think, has come down with the 4th gen. And clashing of the ports, sometime if the patient is very thin, can happen. Despite which of these disadvantages, the robotic surgery is a boon to the patient and also to the medical professional. It solves technical difficulties associated with laparoscopy, including improved physician ergonomics, and surgeons can be proficient with robotics with less number of cases, all with the comfort of sitting and operating, which I really love. Hence, robotic technology is for highly skilled surgeons in highly selected patients and to practice in highly equipped institutes. Please remember, every procedure should suit to the patient and not vice versa. Nail and hammer theory really holds well. Please choose wisely. Make sure you tell every patient what are all the modalities, and then tell her, explain her what are the advantages of each modality, and then we can help her choose what it is. This is a single slide which actually gives me my whole love for robotic surgery. This expressed in this single slide, where we know the good third generation, the fourth generation coming up, very minimal scars. The limitation of the laparoscopy is not there, and accurate surgery, less complication, reduce stress to the surgeon, faster surgeries. So in a nutshell, I say I love this toy. Thank you all for this patient hearing. I hope this pandemic is going to pass soon, and then we are going to meet again and enjoy the luxurious places where Dr. Bhandari has always hosted us. And if any questions, I'm open to take questions.
Absolutely brilliant, Lavanya, for taking us through this journey. And I'm sure with your vast experience, your patients will be benefiting, and they must be very happy going back with a smile. So there's one question in the Q&A box for you, Dr. Lavanya.
Yes.
Do you see do you use or see a role of intraoperative ultrasound imaging for seeing subsurface vessels during robotic surgery?
I have not used, because the light inside the robot is, I think, is good enough. So it's well illuminated. So if you can focus and you can see your blood vessels, I think it is still good. But I really don't think we need an ultrasound here, especially when we're doing a robotic surgery. So I don't know if Dr. Anu, have you ever used this thing? Your
No,
ultrasound for your surgery? I don't think so. We would need that. Because I think the illumination is good. See, what is the point of, if I can, I understood the question, because you want to see, because I think this question is coming from my anatomy slides, where I told it's very important that we need to know our anatomy. The advantage here is when you are putting your camera port and it's illuminated and you have created a pneumo for them. So when it is distended and the pneumo is there and you're focusing your light, you are able to see your vessels. Even in the most of the obese patients that I have tried, I don't think we've had problem in seeing the superficial vessels. And if you know your anatomy, I don't think any surgeon would get into trouble. Trouble comes in when you really don't know your anatomy and you put in the ports blindly.
Dave? Hello?
Hello, Dr. Bhandari.
Dr. Anshumala Shukla is in the audience and she has put some questions. Can you, because we will have a good discussion with these three giants in surgery, and Anupama would head. So if you can include her in the discussion.
Thanks, Dr. Anshu. I'm really glad you are here. So her question is, open surgeries for endometriosis is not recommended at all. I totally agree with her, and I'm also not for it. And as laparoscopy or robotics helps reach inside the pelvic cavity and the pneumoperitoneum helps to remove the spaces, endo ultrasound can be used for localization of fibroid intramural ones. I haven't used. So I think she's also trying to help the person who asked the questions, trying to say ultrasound hasn't got much of a role. And I think she says that urologists are few people who use the ultrasound to see some renal tumors. Dr. Anshu also, I mean, for the person, I'm sorry, I don't know where that question went because I cannot remember the name who asked that question. Dr. Anshu is another renowned robotic surgeon and a very good friend of mine, pretty looking lady, good at her robotic surgeries as well.
That was from Dr. Manish Arora, the question.
Yeah, Manish, I hope that answers your query.
Can I ask you a few questions?
Oh yeah, please. Yeah. While I'm trying to get the...
Yes, so while you're trying to organize.
Yes,
how
please.
robotic arms do you normally use?
I used two. I think I remember only for the first two or maximum three surgeries. First three surgeries I used 3 arms, but I mostly use only 2 arms.
And while you're doing your myomectomies, which suture do you use? Do you use barbed now?
Yes, I use the barbed wires. Sorry, I'll just get the volume low so that we can still answer the questions. This is the video of my daily routine. These are a few infertility patients that I see throughout the day, and they come back with their little grown babies where I have to pamper them. They come. This is one of the little young girl who was born after IVF who came to see me, and they were from Bangla. There's another patient post myomectomy, multiple myomectomies done, and she came back to see us with her baby. And yeah, I think rest of it is just a video that can go on, and all of you while watching. Dr. Anu, I use the barb wires because it really helps us suture and seal the dead space and approximation post all huge myomas once removed. I think it really helps us use the reduce the dead space. So I use the barbed ones.
That's a very sweet video that you're sharing with us. What I want to know is, have you faced any recurrence after myomectomy? In any
Myomectomy, not myomectomy, I haven't, but what happens, I don't know if I want to call it a recurrence, because I told you multiple fibroids we end up removing. I try to be a little conservative there because they're all my fertility patients, and I have to be really careful on how much myoma is still left. So sometimes we end up not removing very small ones, especially if they're not very accessible, very close to the endometrium. And then if it's like 2 centimeters while we're using remote, I think that also, I don't know if I can pause the video and get it a little back. I don't know if Dr. Manish is still on. And yeah, so Dr. Manish, you can see here, it's well illuminated and you can see the vessels. So this is what happens when the pneumo is good. So you have sufficient space there and the light illuminates, and then you can see your vessels very well. This was actually, in fact, a lady who was around 130 kgs, and we were doing a cystectomy for her. So it's very well illuminated. So I don't think we have a trouble or need to use the ultrasound, at least by a gynecologist. So I think, yeah, one of the answers, we have a video proof for that person. And yeah, so I wouldn't call it a recurrence, but rather sometimes I would say it's just there and gets picked up a little later. So they're really small, but I've not had a recurrence especially. They do wonderfully well. They've been symptom free. I've been using the robot for almost 4-5 years now, and nobody has come. Endometriosis is something that I have had few patients come back with recurrence, but then there has been small.
Lavanya, any experience with adenomyomectomy?
Oh, yes. Sometimes I think here it is more than intentional. It's been unintentional, I would say, because when you get in, because your scan says endometriosis, you go there and then we see it as an adenomyosis. Yes. So we end up removing as much as possible. So we reduce the myoma tissue there and then try to flap it up and then suture. Here, I love the suturing when I use the robot.
How has your experience been with the patients who've had endometriosis? What has been, the post-op course in them? And then if you follow them up, maybe 3 months, 6 months down the line?
Wonderful, I would say. Wonderful, because quite a few of them have conceived post-surgery. Like I said, one of the lady on the video was our grade 3 endometriosis. And another, I don't know if you saw the video, and you couldn't hear, she was grade 4 endometriosis. She's already done 2 laparoscopic surgeries outside, 2 previous sections. She came and this was her 5th surgery that we were doing for her. And she was totally symptom free. And then quite a few of my patients conceived quite well. And 2 of them recurred with endometriosis after 2 years. One lady came with the recurrence of almost 2 centimeters. Another one failed to conceive, and then she decided to adopt because we'd already done 2 cycles of an IVF and she didn't want to continue. So these 2 were the not so happy for me situations, but otherwise most of them have done wonderfully well.
That's nice. Could you tell us your thoughts on the younger generation, who are just out there doing their post-graduation, and then they get exposed to the latest technology of robotics, and they would like to jump the bandwagon and get on to robotics right away. So what are your thoughts?
Before that, I think I would say it's a very thoughtful question, Dr. Anu, that you've asked, because it's very important for the young surgeons. And I think I was targeting them. That is why I put these slides on the anatomy, because it's very important to know your anatomy. And just a piece of advice, it's very important that you get a good exposure to your open surgeries, because remember, you get into a complication while you're doing your robotic surgeries, you have to open up. So if you don't know what to do when you open her up, you are in real soup. So get your good experience in open surgeries. That is when later you can venture into robotic surgeries, because the learning curve is so less that you will be able to do well, learn quickly. So don't worry, assist enough number of cases of open surgeries, assist quite a few laparoscopic surgeries, get the orientation, and then start your robotic surgery, which will be an easier transformation for all of you.
Absolutely, I agree with you. There have been a few questions from Dr. Anshu. Good evening, Dr. Anshu. How are you?
Hi, Anupama. How are you?
I'm good. I still remember you are my mentor.
It's my pleasure to see all, to hear about robotics from all of you. And it's really good. I think us as being people who are experienced with both laparoscopy and robotics, it's onus lies on us to make sure that we give the correct perspective about robotics. I mean, we just had a recent debate again on robotics versus laparoscopy. And I think my whole thing here is, you shouldn't be comparing it, because there's a place for laparoscopy still, but there is a very, very big place for robotics as well. And
True.
it's how well you use your technology. And as people who do both, like Lavanya does, you do, showing the perspective of how you as a good laparoscopic surgeon could still adapt and think of robot as being useful. It's very, very important that this message has to be carried across to everyone who's venturing or thinking of venturing into robotics. Because it's a mental block for a lot of people to think why. And I think, like Lavanya showed, fibroids, infertility, anything which requires conservation or preservation, these surgeries are difficult to do, because you have to not only preserve the tissue, but it has to function very well as well. So that's where I think the precision of robot is very, very important. So that's a good talk, Lavanya.
Absolutely, Dr. Anshu, I totally agree with you. I've had this controversies in few talks that we go there and then we do, and then we have a laparoscopic surgeons immediately jumping and saying, oh, what is it that the robot does that we as a laparoscopic surgeons don't do? So first of all, I try to comfort them, telling them, don't worry, I still continue to do a lot of laparoscopic surgeries. Here you need to know when to do what, and for who is the right person who needs to be chosen to a robotic surgeries, because cost is definitely a factor that we need to be understanding. And like I mentioned, sometimes cost is not a factor, because you need to see the end result and what are you giving her. So that is when you need to take a rightful decision on behalf of the patient and try and make them understand why robot is more important for her. And I would really say robot is a boon to me, especially for my fertility patients. And I don't think there's anybody other than Anshu would agree with me more than this.
That's true. Good. Glad to see that. I think I have asked you one question about tubal recanalization, actually. Just a quick thing. I mean,
tell me, you can tell me the question. I can't see the question.
Yeah, that's right. So would you cannulate the tube before you anastomose? Would you...
Only last week we did one. So what happens sometimes, going through a lateral end is a little difficult. So especially these are patients who've already had a tubectomy done. So we try to freshen the ends. So we try to cannulate. So it's easy for us to pull in. One of the tubes which I did last week, it was very difficult cannulating and then having a little this thing. But then we try to freshen out, and you can nicely see that pouting out of the mucosa. That is when it is really good. You won't believe it. I was very apprehensive because I couldn't cannulate, and then I was worried. I had to freshen the ends like almost twice. So I was wondering if the surgery is going to be really good or not. Post surgery, when we sutured and we pushed in the dye, that was the better side compared to the other one. So yeah,
Nice.
we try and calculate.
Also, when you're using for recan, you have to use very fine sutures.
Yes.
How fine is your suture, and have you thought of using the the 5 mm ports of the pediatric robotics? You know, you have the SI, and SI has a pediatric robot set. And
Yes.
at least when I do laparoscopy for tubal recan, I use the 3 mm ports, so that my needle holder is very, very thin, and the instruments are finer. So I'm able to use a 6-0 proline also very easily. Even though needle is very, very fine. Similar with
Yeah.
robotics, rather than using our with the SI, of course, XI, the instruments are slightly less bulkier, but with SI, you will sometimes find it difficult to manipulate the needle, such a fine needle. So, you could use a pediatric set there. It works. It works very well.
I think that is a point that I would like to note, and definitely use it. Like I said, robot, I already mentioned when I started the tubal recanalization that I'm an infant for that surgery. I've just done a couple of them, but I would definitely consider your advice. And I think it's a very good option that you gave me, Dr. Anshu, that I would definitely try using the pediatric ports for this. I think it's an excellent idea. I think I will do that and get back to you on the results.
Would love to catch up with you, and congratulations on a lovely talk, and congrats, Anupama. Nice to see you here, and keep up the good work.
Thank you so much.
Thank you. Thank you.
Thank you. So
Thank you. Yeah, I think I can see the time, and I think I've gone on for a very long time.
Yeah.
This only shows I'm still not tired. That only shows the passion of how robot has really inspired me, and I'm sure that really tells you of how much I love this robot.
Absolutely. We all do, we are in it together, Lavanya.
Yes, I'm glad. I have wonderful people with me in this journey.
Ladies, thank you so much for your time today. It was really, I learned a lot. And, Dr. Kiran, I appreciate the fact that you make sure that you give your patients all of the options and let them decide. You may know what's best, but they may not always agree. It must be tough when you have to go back and do an open instead of using the robot. But it's nice that you give everybody the opportunity. It's also neat that your graph near the start of your presentation showed that the gynecologists are actually matched almost neck and neck with urology now for the use of the robot. I didn't realize that.
I hope I'm not scaring you there. No, don't worry. We're not going to venture into your field. We're just trying to make sure that we are safe. And
I'm just a TV guy. I'm not. I'm not a surgeon, but I've learned so much with these webinars.
No wonder Dr. Bhandari is not commenting. He must be angry. So no, we're not getting into your field. I'm just making sure the patient's fine.
Well, thank you for your time today. Once again, I want to thank both Dr. Kiran and Dr. Bahadur, who also is going to be presenting on a webinar on December 12th for us. But I want to thank you for your time today.
At the outset, I must thank Lavanya and Anupama for sparing their precious Saturday evening. I really enjoyed your talk, Lavanya.
Thank you, sir.
The most important carry-home message for me is the passion you carry. And I have been working with surgeons for almost over 4 decades, and that's the only thing I looked for when I selected a surgeon. Because these knowledge base you can increase every time, but if you're passionate about doing something, even open becomes a robotic surgery for the patient as far as outcomes are concerned. So continue loving what you do and continue doing what you love.
Thank you so much, sir. Thank you.
Thank you so much for responding, and we look forward to more such programs. And don't worry about this thin audience, because we planned it in a manner that we have much more YouTube videos, so people.
Yes, I understand that. I know.
Yeah, so that's not a challenge. And whenever you are talking something skill, even if you benefit 4 people, it makes a huge difference. It's very nice of Anshumala to have joined, and I spotted her in the participant box, and then I thought it would be a good opportunity to include her.
Thank you, sir.
Anupama, thank you very much, and we will talk after this for a while to see, discuss about your subject. Thank you. thank you everybody for participating in this webinar.
Thank you so much for the wonderful opportunity, sir. Thank you for all your blessings.
Thank you
God
for
bless
all your
you.
work.
Thank
That
you
was
so
a very thorough presentation.